Ladies and gentlemen, it's a great honor for me to be in Winnipeg and give a report on the Bromid study, which is still not published. We have submitted the paper, and we're hoping that the paper will be accepted very soon. It is a special option for me to be here because many of you are patients who have the disease, or some of your acquaintances will have the disease. And we have such organizations in Germany too, and I'm the chairman of one of these organizations. And I think it's tremendously important to have such educational meetings for the patients, and also to have expert doctors. And during my lecture tour through Canada, I realized that there are many experts in the field of neuroendocrine tumors. I think more than in Germany. And Germany has more than 50% of the population of Canada. The problem is, and I've spoken with one of the patients here sitting, is that the patients do not know exactly where the experts are sitting, because the primary care doctors do not know sometimes where the experts are. And I think this is the task of such an organization, of your organization, to inform newly diagnosed patients where they should go, where the experts are. What I wanted to discuss with you is an extension of that what you heard, treatment of neuroendocrine tumors with special substances. And the first issue in treatment of neuroendocrine patients is the control of symptoms, and you see in blue the different functionally active tumors as insulinoma, gastrinoma, Katz-Nutt syndrome, and so on. And you see frequently the word somatostatin analogs, and you don't need these analogs only in two instances, not that is gastrinoma, the Zollinger-Ellison syndrome, because gastric acid secretion, hypersecretion, can well be managed by proton pump inhibitors, and the hypersecretion of insulin can, in the preoperative setting, because the surgeon is the man who can cure the patient from insulinoma. In the preoperative setting, diazoxide is one of the agents which inhibits insulin secretion and prevents hypoglycemia. This is a patient you also have seen, such a patient with a Katz-Nutt flush, which can be treated, such a patient with octreotide. And this is a young female woman with a glucagonoma syndrome with the necrolytic migratory erythema. This patient had this symptom, and this exanthema went to a dermatology department. They couldn't detect the reason for that, and since the patient developed anemia, the patient was transferred to an internal medicine department where an ultrasound was performed, and then pancreatic tumor and liver metastasis appeared and were detected. Biopsy gave neuroendocrine tumor. This tumor was full of glucagon, and glucagon levels were elevated. The main topic of my speech is control of tumor growth, and Dr. Dorisio and Dr. Wang and Dr. Ezzat have discussed the different possibilities, which treatment options are available, and how to treat, whom to treat, when to treat. These are the open questions. Chemotherapy, interferon alpha, many ablation methods, then the radioligand therapy, and you will hear this afternoon 2 lectures from Dr. Baum from Germany and Dr. Buskomp from London, and Dr. Dorisio also has mentioned this method. I personally do not know where is exactly the place, and a little bit disagree with Dr. Dorisio that I would offer this method now patients directly after surgery. and I would say that the place may be a little bit further behind, but this is an open question, and open questions can only be solved by control studies, and I'm hoping very much that such control studies will be available soon. Surgery, I cannot speak about that. We heard the next speaker will do the job. Embolization, we have heard about. I'm speaking on targeted therapy. And what I mean with targeted therapy is shown in black. There are on the cell surface growth factors, and the treatment is, for instance, bevacizumab, which we know from colonic cancer, or we have hormones and we have ligand binding inhibitors, or we have somatostatin receptors, and the binding substances are, for instance, octreotide, lanreotide, or the new substance pasireotide, which binds to all 5 somatostatin receptors. We have tyrosine kinases and sunitinib or sorafenib, inhibitors of these tyrosine kinases. And there is a mammalian target of rapamycin in the cell, and the inhibitor is everolimus. And this is summarized in a slide which shows you here the cell membrane, and on the cell membrane we have different receptors as growth factors. We have somatostatin receptors. Here are the growth factors, and we have in the cell tyrosine kinases. And you see if these receptors are stimulated or inhibited, then there is a cascade of events within the cell, and then follows gene transcription, and the result is either cell proliferation, stimulation or inhibition of cell proliferation, angiogenesis, stimulation or inhibition, endothelial proliferation. And I think it's important, I had a discussion with Dr. Esat at the beginning of this week. We don't know exactly where all these substances, especially, for instance, somatostatin, are they directly acting on the cells, or are they acting, for instance, on the endothelium of the vessels? I'm speaking on somatostatin and its effects on growth of neuroendocrine tumors. And as you see here, we have direct effects on the somatostatin receptors, which inhibit apoptosis or cell cycle. And we have also indirect effects of somatostatin analogs as endocrine or paracrine effects. And also these result in the inhibition of trophic factor secretion, inhibition of angiogenesis, and the immune system modulation. Why is this important? Because there are some patients who are, for instance, octreoscan negative. And we have the impression that although these, or some of these patients may respond to octreotide, and this is possible via indirect effects. Prior studies with short and long somatostatin analogs have demonstrated in the mid-80s or the beginning of the 90s of the last century, complete tumor disappearance. You have heard by Dr. D'Orisio that the most frequent observed events after treatment with targeted therapies is stabilization of the disease. But these case reports reported complete remission. And even in the last year, Professor Öberg from Uppsala published a patient with a Zollinger-Ellison syndrome due to a malignant gastrinoma, and during octreotide therapy, this tumor disappeared. In following controlled studies, only stabilization or partial regression has been observed, never complete tumor disappearance. Are these observations wrong, or is there a background? We believe that well-differentiated neuroendocrine tumors can grow in a different way. That is the spontaneous growth of these tumors. They can grow relatively rapidly. They can grow and they can be spontaneous stable diseases, then again growth and so on. But you see, there may be also patients who have spontaneously decrease of their growth. And we observed a 50-year-old female patient who had diarrhea, and due to the diarrhea, they went to a physician and he made ultrasound of the abdomen and he found a pancreatic tumor and liver metastasis. The tumor was biopsied and was a well-differentiated neuroendocrine tumor. Patient came to me to Marburg, and since the tumor was a well-differentiated tumor, low Ki-67, I tried to convince the patient not to be treated at once, but we should look what happens with the tumor and please come after 3 months. The patient was a nurse and she agreed to that and came later after 3 months again. And the tumor didn't increase in size, also not the metastasis. The tumor decreased a little bit. After further 3 months, tumor decreased again. And this continued at least for 2 years. And then the tumor was constant, did not grow and did not regress furthermore for another 5 to 6 years. And then tumor started again to grow, and then we added to the patient various substances. And then I asked the patient, have you done anything after we had our first discussion and discussed nothing to do? Then she said, yes, I was in the beginning in the menopause and I had estrogen substitution. And I stopped estrogen substitution. And I believe, I'm convinced that this tumor had estrogen receptors, and he regressed after the substitution was stopped. Would I have given this patient octreotide and would have published these results? Everybody has believed this is the effect of octreotide. No, it was a spontaneous regression, and this may be very rare, but it can be occur. There are several studies available, not controlled studies, not placebo-controlled. Why is placebo-controlled so important? I think I have shown you that in the case report with the patient which was not treated by octreotide. And to prove the efficacy of octreotide, you must do once a placebo-controlled study. And these studies were not available. The other thing is, Dr. Aza has explained to you that the tumors may be extremely different. Hindgut tumors, midgut tumors, pancreatic tumors, functionally active, functionally inactive tumors. And most previous studies had included a heterogeneous patient population with neuroendocrine tumors of different origin and perhaps biological behavior. And the majority of studies did not include treatment-naive patients, but patients who have been treated before. That also can influence the response to a specific treatment, because you don't know whether a specific treatment has eliminated some tumor cells which may respond to a treatment schedule which have to be investigated. Therefore, we performed a study which is called PROMIT, and PROMIT stands for placebo-controlled, double-blind, prospective, randomized study of the effect of octreotide, LRR, in the control of tumor growth in patients with metastatic neuroendocrine midgut tumors. And I'm standing here for the PROMIT study group. And as I told you, we included only patients with tumors situated in the lower midgut, that means in the lower jejunum or in the ileum, and excluded all the other tumors. And we discussed the possibility of or the observation of an increased incidence of these tumors was discussed by the previous speakers, and I will not comment on that. But you see also mid-gut tumors increase in number, and the upper curve is devoted to the lung and bronchial tumors, which are the most frequent. And then come the mid-gut tumors, and we have chosen mid-gut tumors because they are frequent tumors. We have heard about the symptoms of these tumors. Functionally active tumors have the carcinoid syndrome and with flushing diarrhea and so on. And we included also functionally inactive tumor also. Dr. Eze has shown you that these tumors differ also by histology from functionally active tumors. These tumors have only unspecific episodic to severe abdominal pains. And Dr. Orizio and Dr. Izzat have shown you, or Dr. Wong, a picture showing you that it takes years until a tumor arises and grows. And after some years, episodic episodic pains may appear, and it takes another several years until flushing or diarrhea may occur. That means if carcinoid syndrome appears, this is at the second part of the whole length of the disease. Our study, this PROMIT study, had two arms: octreotide LAR 30 milligram every 4 weeks, or placebo every 4 weeks. The primary endpoint was time to tumor progression, and the treatment was continued until CT or MRI document tumor progression. Follow-up will be done until death of the patient, and CT and MRI was evaluated by a blinded central reader. This is important for controlled studies because there are differences in the evaluation of different radiologists, and therefore it's very good to have a central reader for such studies. That was a randomized double-blind placebo-controlled phase 3b studies performed in 18 centers in Germany, and we included 85 patients from a planned 162. Now you are asked the question why you included in 8 years only 85 patients. The reason is that doctors and patients are not frequently willing to participate in a placebo-controlled study because they fear the fact that they may be included in the placebo part. That is an important fact if you are performing a controlled study. Also, doctors don't like too much placebo-controlled studies. Then this was a double-blind study. That means the octreotide and placebo had to be sent from the manufacturers to the pharmacy of a hospital, and the pharmacist gave the substance then to a nurse or to a physician who was not involved in the study, and he performed the injections. Therefore, primary care doctors in the periphery could not participate in such a study, and patients who lived not close to a center had to travel many kilometers, sometimes more than 100 kilometers, to get the injections. And also that the patients did not like very much. And therefore, there were several reasons who contributed to the fact that we included only 85 patients. Therefore, in summary, newly diagnosed treatment-naive patients, histologically confirmed, locally inoperable or metastatic well-differentiated mid-gut nets, functionally active or inactive mid-gut tumors, primary tumor located in the mid-gut, or there were some unknown primaries, and we believe that they belong to the mid-gut if no evidence of a primary tumor outside of the mid-gut was given. No curative therapeutic option available, and measurable tumor by C and MRI. Primary endpoint, time to tumor progression. Secondary endpoints, objective response rates, survival, biochemical response, symptom control. This is a busy slide, but it's an important slide because it shows you time since diagnosis was the median was 4.3 months. That means the time point between diagnosis at a specific time and randomization was only 4 months. This is very short. Ki-67 is a marker for well differentiation and slow growth was less than 2% in 95% of the patients. And Dr. Orizio mentioned that also he is measuring hepatic tumor load. There are no published studies in the literature who have in targeted therapy investigated the hepatic tumor load. We did it because there is a strong correlation between hepatic tumor load and, for instance, chromogranin A levels. And chromogranin A levels, the higher they are, the shorter is the survival, and there is a parallelism between survival and hepatic tumor load too. And to our great surprise, 75% of the patients had a hepatic tumor load below 10% and only 20 to 25% a hepatic tumor load between above 25%. What that means, if you have a patient or if there is a patient with a newly diagnosed disease, with a fresh disease, then it's more likely that he has fewer liver metastases than a patient who has a disease which is known for more than 10 or 15 years. Therefore, 75% is very understandable. What means in a newly diagnosed patient a hepatic tumor load above 25%? That means, obviously, that despite very well differentiation of the tumor, this tumors grows faster. And it would be interesting to see whether this has any influence on the therapeutic efficacy of our substance, namely octreotide LAR. And this is the most important result of the study, showing in red the effect of somatostatin analogs with a median time to tumor progression of 14 months, and in the placebo group in blue, the median time to tumor progression was 6 months. I personally find that the placebo group is very interesting because you see there are some patients who progress rapidly, that means within 3 months. Others progress, for instance, this group, within 3 to 6 months. But there are 50% of the patients who progress after more than 6 months. And we have the impression that especially patients with a slower spontaneous tumor growth, they were without therapy. This is spontaneous tumor growth. They are those who respond to octreotide. And why we investigate survival? Because we would like to know whether a response to treatment in the early phase is related with higher survival. But we do it also for the reason to know whether patients who have a slow spontaneous progression compared to those with a more rapid progression have an increased survival or differ in survival. The most favorable treatment outcome in patients, we investigated prognostic factors for time to tumor progression, and most favorable treatment outcome was observed in patients with a low hepatic tumor load. If we would not have measured hepatic tumor load, everybody would believe that octreotide is effective in newly diagnosed patients, irrespective of tumor load. We have done this evaluation and could only, and I show you this in this slide, this is exactly what I wanted to show you, patients with a hepatic tumor load less than 10%. All these patients are malignant. Also the patients with zero tumor load, they have lymph node metastasis. And you see there is a great difference between placebo and octreotide group. And this group represents the patients with a higher tumor load there is very well possible that also patients with a higher tumor load respond to the treatment, but not the newly diagnosed patients with a higher tumor load. If a tumor load develops very, very slowly, then such patients may again respond to octreotide. We found also that a resected primary is related with a more favorable outcome. I personally believe that the resection of a primary is a surrogate marker of the amount of liver metastasis. Then surgeons would more like to operate on a patient who has fewer liver metastasis than patients with a high hepatic tumor load. And I very much like to hear the remarks of our surgeons who will speak after me, because everything what is published in the past are retrospective studies describing that resection of the primary is related with increased survival. But nobody described the tumor load in these patients. The benefit was also observed in functioning and non-functioning tumors. Although Dr. Aza has told us that these tumors may differ in histology, they respond both to octreotide, which I think is a favorable result. So, survival has not been reached, median survival, and we cannot say at the moment whether there is a real difference. The problem is also that almost all patients included in the placebo group and all were progressive, as you have seen. The latest were 32 months. All these patients received afterwards octreotide LAR. Therefore, an octreotide-free group is not thinkable, and that may influence the survival data. But I have shown you that there are other reasons why we follow up survival, and we do it. Indicates prolonged time to tumor progression in response to treatment with octreotide LAR, prolonged overall survival. And we have done also a study for this question, which was published in 2005. In this study, we observed the hypothesis was that in neuroendocrine tumor patients, octreotide plus interferon alpha is equally effective as octreotide. We investigated that and we found there is no difference. That means if you investigate this question in a controlled prospective study, there is no difference. But we observed that in this study, in both arms, were patients, as I showed you, with the PROMIT study, with stable disease, or also some patients with partial regression. And then we compared the survival of these patients who responded with stable disease and partial regression with those in the yellow curve who were only progressive during the study. And you see the post-observation period was nearly 10 years, and you can see how long controlled studies may last in neuroendocrine tumor patients because they are growing so slowly. Therefore, some of these studies cannot be done in the lifetime of a researcher because he will retire and the study will then be finished or will not be or will done by earlier co-workers. And the same is true for the PROMIT study. I am now retired, but I follow up my patients still, despite survival. And this you show that the responders live longer than non-responders. And this may indicate, this is not a proof, but that it may indicate patients who respond to octreotide with increased time to tumor progression live longer. Safety, I would like to compare safety with other targeted therapies. There is a publication from Kulke et al. In the JCO last year with sunitinib. Also, I have shown you this is a tyrosine kinase inhibitor. Then everolimus, that is the mTOR inhibitor, a very important signal, it is a signaling cascade of a tumor cell, and PROMET stands for octreotide LAR. And you see the side effects are much more frequent in the sunitinib and everolimus studies compared to the octreotide study. This is, for me, a very strong indicator to start a treatment in a newly diagnosed patient with a treatment with low side effects. Why low side effects? Because many patients, more than 70% with malignant disease, have a very nice life quality. They have an impaired life quality, and they wish to have a substance as treatment which is first effective, but second has low number of side effects. This is for me, which speaks for octreotide LAR as a first treatment schedule in patients with newly diagnosed disease. In summary, octreotide LAR significantly improves time to tumor progression in patients with metastatic, well-differentiated midgut nets, with functioning and non-functioning nets. Patients with low hepatic tumor load had a significant increase in time to tumor progression, and median survival has not been reached. The study was not designed to investigate this question. Conclusion, octreotide LAR should be considered the standard of care in patients with well-differentiated midgut tumors, and octreotide is now recommended for patients following cytoreductive treatment. And this is the team I worked with members of the Department of Internal Medicine, Department of Radiology, Institute of Medical Biometry, Coordinating Center for Clinical Trials, and below you see the participating study centers with many cities in Germany. And last slide gives you an impression on the city where I lived. That is Marburg city, a medieval city with a very old church, Gothic church. This was actually the first Gothic church built in Germany, remembering to Saint Elizabeth. Elizabeth was a queen living in Thüringen, and was married, but her husband died, and she was a widow with 23 years, had 3 children, and I think with 28 years they came to Marburg just to care for sick people, and there they were buried. This church was built, and on the hill you see the castle of Marburg. This where Philip lived, who founded the Philip's University. This was the first Protestantic university, I think, in the world. And on this castle, Luther and Melanchthon discussed religious problems. And 500 years later, we did the PROMET study. Thank you very much for listening to my talk.
Thank you, Dr. Arnold.